My name is Ed Pino. I am Assistant Professor of Pediatrics at Marshall University School of Medicine in Huntington, West Virginia. Very pretty country. You ever want to come out and visit us? We have beautiful foliage in the fall. Today, in the next couple of days, we're going to be talking about pediatrics for your review for USMLE Part 2. Okay? Have a lot of material to cover. We're going to highlight all the hot topics here. Like I said earlier, questions, we'll try to leave them for the break, if at all possible, so that we can get all the material in. We'll get started. You're also the recipients of the new revised, improved notes. So we'll see how these have been. A lot of people have been working on them, and they're really good. And you'll notice the difference. First thing we talk about, we'll go over the first question. We have just like a little intro question. A newborn infant at birth is noted to have acrocyanosis, a heart rate of 140, grimaces to stimulation, and is active and with a lusty cry. What is her APGAR score? Now, generally, the APGAR score, the way that it will be asked on the exam, is not necessarily like this. It may be, but you need to know the significance of an APGAR score anyway for other questions. So, for example, you need to know what is the significance of a low APGAR score. For example, they talk about that, and they might mention a child who has necrotizing enterocolitis, and you know that the low APGAR score might put him at higher risk. Does anybody know how the APGAR score was developed, or who developed it? Okay, so you guys are winning the first chocolates of the day already. Over here. In the back is going to be hard. Who in the back said that? Now, you're next to her. You're not in the back. All the way back there? You're not allergic to chocolate? Okay. Oh, sorry. And way in the back. That'll keep you awake. Okay. I don't want anaphylaxis. If you're allergic to chocolate, don't eat it, please. Virginia APGAR was an anesthesiologist who developed this APGAR score, and the mnemonic for APGAR is APGAR, A-P-G-A-R. It's a very useful tool for immediate assessment of the child. It gives you a good perinatal assessment of the child. It is not used for later on in life. What does a low APGAR score mean 15 years from now? It's hard to say. But it is very useful for right now when the baby is born. It's also very useful in determining how your resuscitation is progressing. The second chapter, I believe, is resuscitation. And the APGAR score in a neonate is very useful because if the APGAR score is going up, either you're doing something right or the baby's getting better on its own, but either way, that's a good sign. The APGAR score, as you see up here, and you have it in your notes, is divided into 5 subjects: the heart rate, respiration, muscle tone, reflex irritability, and the color. And you have the actual mnemonic in your notes: appearance, pulse, grimace, activity, and respirations. And that the first letter is APGAR. We'll spell out APGAR. The score is a 0, 1, or 2 points. A heart rate of 0 is a 0. Heart rate of less than 100 is a 1. Greater than 100 per minute is a 2. No respiratory effort is a 0. A weak cry is a 1. A very vigorous cry, as they describe in the question, a lusty cry, is a 2. The muscle tone, if the baby is completely flaccid, that's a 0. If there's some flexion of the extremities, that's a 1. If the arms and legs are well flexed, that's a 2. Reflex irritability sometimes can be translated in the question as to what the baby does when you put a catheter in its nose or when you bulb suction it. What does the baby do? If the baby doesn't do anything, that's a 0. If it does some motion, it's a 1, like maybe a little sneeze or something. But if it cries and puts up a real stink and tries to withdraw from you, that's a 2. And then the color of the body is blue. All over is a 0. If you have a pink body or blue extremities, that's what they call acrocyanosis. That's that word in the question. Acrocyanosis means that just your hands and feet are blue. That's a 1. And if you're pink all over, then that's a 2. So obviously the highest score you can get is a 10. The lowest score you can get is a 0. And the score is given at 1 minute. It's also given at 5 minutes. And if the child is ill enough that you are doing resuscitation efforts after that, you give it every 5 minutes. A score of 0 to 3 at 1 minute requires resuscitation. Now, the caveat is you don't wait for 1 minute. If the child has a very low score and it's 30 seconds, you're not going to sit there by the watch and say, well, you've got another 30 seconds to go. You're going to be doing something for that child, for that infant. So you don't want to have to wait all the way for 1 minute. You should be doing something. But a low score at 1 minute requires resuscitation. Again, as I said earlier, poor scores at 5 minutes don't predict subsequent cerebral palsy, although a poor score at 20 minutes, which means that you're still doing something for this child, is predictive of higher morbidity or mortality. 8, 9, and 10 is good. 0, 1, 2, and 3 is poor, even up to 4. 5, 6, and 7 are fair scores. Okay, so that's the APGAR score. They can ask it as just like you had in this question, or they can say the components of the APGAR score include all of the following except. They're not asking those type of questions that much anymore. Or they may have an APGAR score in the text, and you have to interpret that as knowing that's a good score, that's a fair score, that's a bad score. What does that mean? Okay? Okay, moving along to the skin. We have a newborn infant has a blue-gray pigmented lesion on the sacral area. It is clearly demarcated and does not fade into the surrounding skin. What is the most likely diagnosis? Before you turn the page, what is it? Mongolian spot. Okay? So here you have a Mongolian spot. Mongolian spots are more common in dark-skinned races, although up to 5% of Caucasian infants, newborns, will have it. When I say the word newborn, we need to know the definition of newborn. Okay? A newborn is a child, any child under the age of 28 days. Okay? And we use 28, not 1 month, because some months have more days than others, but it's technically it's 28 days. So a newborn with a Mongolian spot is very common. Here it is. It looks like a slate color, but notice that it's very sharply demarcated. Okay? The differential diagnosis, the main thing on this is going to be what? A bruise, like the bruise of child abuse. So you want to make sure that you've documented that these are Mongolian spots. They can occur anywhere on the body. They are typically on the buttocks and the sacral area, although here you have a child with a Mongolian spot that's a little higher up. Here's another one, there's another one, and here's the classic one here. But notice that it does not fade into the surrounding skin. That's really important when you're reading the test question. Because if you see that it doesn't fade into the surrounding skin, you don't have to worry about that being child abuse. That's part of your answer. You know that's a Mongolian spot. It's caused by a heightened receptor response to melanocyte-stimulating hormone, and they tend to fade away over time. It takes some months to a year or two to go away. Okay? Other things that you'll find in the skin in a newborn include erythema toxicum. Now, they will try to confuse you on the exam because they're mean people, right? They want you to get it all wrong. So they try to confuse you with staphylococcal scalded skin. Erythema toxicum is very common. Something that you will find in the pediatric part of the exam is that a lot of the things that are being asked are normal. Why? Because the spectrum of normal in pediatrics is so broad. And, everything else that you're doing as adults, that there are certain things that might seem abnormal in an adult, but it's normal in the child, like heart rate, for example. So erythema toxicum will appear in a lot of newborns. It does not, I repeat, does not appear in the first day of life. So when you're reading your test question, it's very important to look for that when you're trying to differentiate that from some other skin condition at birth. Okay? It'll usually show up after 24 hours, usually second or third day, but certainly not within the first 24 hours. It is characterized by these erythematous areas, these little reddish, they're macules, which can become actual blisters and pustules. And so you have some redness up here, just kind of diffuse. This one's running into the other one. You have some here and here and here and down here. And it's very migratory, so that the next day you might see, for example, maybe this is clearing up, but now maybe the baby has some more over here on the arm. It's very migratory. The pustules, if they're scraped, you will see them, they will have lots of eosinophils. So that's a clue also that it's erythema toxicum neonatorum. Okay? And erythema, that just means red rash of the newborn. Okay? Dermatologists give you really fancy Latin terms because they can charge a lot more. And the pediatricians, we're cheap, so we just call it red rash of the newborn. But for the exam, you need to know the dermatology word. It's erythema toxicum neonatorum. Staphylococcal scalded skin, on the other hand, may be present in the first day of life. They will present with pustules. The skin tends to start to peel off. Okay? If you scrape it, it'll form a blister, kind of like a burn, and it peels off. And if you scrape the skin, those little pustules, you will see that it'll be full of neutrophils. So erythema toxicum, eosinophils, staphylococcal scalded skin, neutrophils. And those babies look very ill. They are toxic appearing. They look like they've been burned. They can have Staph aureus sepsis. So they are a lot sicker looking. And when you scrape that skin and it blisters up, what's that called? What's that sign? Nikolsky sign. Okay, who said that this time? It was over that side. Nikolsky. Back there? Okay, Nikolsky sign. Someone in the middle said it too. Right there. You? Yeah. Okay, so Nikolsky sign, you'll see that it's not pathognomonic of staphylococcal scalded skin, but you look for that with those kind of conditions. You won't see that in erythema toxicum. And erythema toxicum is basically just treated with reassurance of the parents. This is sebaceous hyperplasia, sebaceous gland hyperplasia. They look like little whiteheads, right? Okay? And those are just plugged up pores in the skin, and you leave those alone. This is milia. Now, this is a fine white milia, so it's called milia crystallina. If it was red, they would call it milia rubra. But this is milia crystallina, and again, it's just like some plugged up pores, some inclusion cysts. Sometimes you will see in the mouth, if you look right there, see right there? That one and that one. Those are also known as Epstein's pearls, and they're very typical on the soft palate right in the midline. That's known as Epstein's pearl. That's just a collection of stratified epithelium, and it tends to go away. And you can find Epstein's pearls anywhere that you can find mucous membranes, mucous tissue. Okay? So those are Epstein's pearls. Those are also very normal. That's not to be confused with what's known as, it's not in your notes, torus palatinus. Okay? Torus, T-O-R-U-S, palatinus, P-A-L-A-T-I-N-U-S. And that is an actual deformity of the hard palate, where it kind of curves down a little bit. That's going to be permanent. It'll be covered up by mucous membrane, but it's just a little outpouching of the hard palate, and it's permanent, but it doesn't cause any problems. Another finding in the newborn skin is what we know as cutis marmorata. Okay, if you see, it looks like cobblestoning. It looks like all these little, they're almost like little blood vessels. Okay, sometimes when the baby is cold, they will get like this. Cutis marmorata is secondary to some vasomotor instability, and they don't maintain temperature well. So when they get cold, they'll do this. And generally, as they get older, it gets better also. It can also be, you can also have a cutis marmorata telangiectasia congenita. That's a whole different thing. It does not go away as they get older. And sometimes you'll see cutis marmorata in patients with Down syndrome. This is neonatal acne. Right there, there, all of this face is neonatal acne. That's what the cheap pediatrician calls it. The dermatologist calls it acne neonatorum. They charge more. Okay? And again, it's just a heightened receptor response to circulating estrogens, and they will get that. It's not necessarily seen right at birth. It usually shows up maybe at about a week or so, maybe 2 weeks, and it also goes away, and you really don't need to treat them. You don't need to put them on any of the, adolescent, the acne medicines. You don't need to do any of that. Birthmarks in the newborn. A newborn has a flat salmon-colored lesion on the glabella, which becomes darker red when he cries. What is the best course of management? That's a typical kind of question. It's 2 questions in one. First of all, they're asking you what it is, but that's not the answer. They're asking you, what is the course of management? You need to know what it is. Well, that's a salmon patch. It's also known as a nevus flammus, and you don't do anything about it. The best course of management is reassuring the parent. So the salmon patch is going to be seen over the eyelids, the bridge of the nose, and very commonly on the back of the neck. It's also known as a stork bite. Okay? And on the front, on the eyelids and on the bridge of the nose, they're called angel kisses. The angels kiss them on the forehead before the stork picks them up to take them to the nursery. See, and you guys had OB and you thought that the baby was born differently. This is how they're taken by the stork. These tend to go away. About 50% of babies will have them when they're born, but not 50% in this room have them. I guarantee you that. The ones on the back of the neck tend to stay, if they're going to, but your hair covers it up. And the ones on the face are the ones that more commonly go away. Again, it's just reassurance. You do need to distinguish this from a port wine stain. And I'll show you a port wine stain in the next couple of days. I will show you a picture of a child with port wine stains. Port wine stains are hemangiomas, basically. They do not go away. There's another big stork bite there and back here. Okay, that's a salmon patch. It's flat. Okay, this is known as a capillary hemangioma. It's also known as a strawberry hemangioma. Guess why? Okay, so there's a capillary or strawberry hemangiomas. They will usually start out as a flat macular lesion. So sometimes they may not even be present at birth. And then as the mom brings them in at 1 month of age, or says, "Doctor, look at this." And then at 2 months of age, it might be bigger. Some of them are already bigger. They tend to grow in the first year of life. And then they'll start to go away slowly. So for the most part, you don't need to do anything about them as they regress. You don't need to go in and cut them out because they're a bloody mess, because all they are is a bunch of blood vessels. You don't need to laser them or anything unless they are over a vital structure. Now, one thing you do need to keep in mind is if they give you a question and they describe that the baby has one of these on the skin and this baby has stridor, you should be thinking of a subglottic hemangioma, a hemangioma in the airway as the cause of the stridor. Now, it doesn't happen all the time, but for test purposes, that would be a nice hint. Okay? Here's another capillary hemangioma or strawberry hemangioma. This one's actually bigger than the first one you saw. It's not compromising a vital structure. It's not causing the eyelid to close and you can't use the eye. So we're doing fine. And actually, this one, even though it looks worse, is actually getting better. As it gets better, it tends to get very like a bluish color, and it tends to get very boggy, and it feels almost like an abscess. Okay? But that's when it's getting better. And here is the same patient. This patient is all the same on the slides, just followed over the course of a few years. Here it was at about 1 to 3 years of age. Here it is at about 5 years of age, and here is the same patient at about 7 to 9 years of age, and you really can't tell. It just went away. So you don't need to do anything about them. This is known as a nevus sebaceous or a nevus of Jaddison. It will be present at birth. And it's just a almost salmon-colored, fleshy-colored, and you notice there's no hair. There's no hair coming out through it. When you look at it, it looks almost like a wart that was squished. It's only on the scalp. There's no hair on it. And basically, you don't need to do anything about it. You follow them until they're about adolescence, and then you take them out. There is some chance or risk of it becoming malignant. So you follow them, and they're not getting big fast. You leave them alone. Finally, by the time they're adolescents and you're not growing anymore, you can take this out. Café au lait spots are other birthmarks that can be seen, sometimes associated with syndromes, sometimes not associated with syndromes, and I'll show you those when we talk about a certain syndrome that has them. Let me just... Okay, this is just an extra here. This is what we call it's not in your notes, it's called a harlequin baby. Remember when I said cutis marmorata? I mentioned there's some vasomotor instability. This is the same thing. It is known as a harlequin baby, Harlequin, harlequin baby. And what you notice down here in the expensive seats, right, you can see this line pretty much right there. And you see that the baby looks a little bit darker or redder on the bottom. And up here, the baby looks a little bit more pale. Now, if I were to take that infant and flip him over onto the other side so that this would be on the bottom, then this side would start to get a little bit redder, and this side would start to get pale. And that's just, again, some vasomotor instability, vasomotor immaturity And as the baby gets older, that tends to go away. But that's known as a harlequin baby. Some injuries. Babies, they're going through the birth canal. They get beat up. So some of the things that you can expect in a newborn, which you'll get tested on. And that includes the cephalhematoma. And this is what you see right here. Okay, you see this collection of fluid underneath the bone. And it's very important to know the difference between a cephalhematoma and a caput, because they will ask you that. That's where they're going to try and fool you. So a cephalhematoma is a subperiosteal bleed. Since it is beneath the bone, it is limited to the bone. Since it is limited to the bone, it doesn't cross the suture lines. Okay? Whereas a caput is a scalp swelling. So it's above, and it can cross suture lines. Other ways to tell them apart. Cephalhematomas usually get worse over the next few days. They may not be very big the first day or the second day, and then they might get a little bit bigger over the next few days, and they take longer to resolve. They can sometimes take weeks or a couple of months to resolve. A caput starts to get better as soon as the baby comes out. It's basically due to pressure from being in the birth canal, and as it comes out, the pressure is gone, and it starts to go away. Kind of like when you bump your head on something, it swells, and then it goes away quicker. So that's how you tell the difference, okay? Here's just to show you a differential diagnosis of a cephalhematoma is going to be a depressed skull fracture. Now, not every, there usually isn't one underneath there. And so you don't need to x-ray every baby with cephalhematoma. Right? So here's the suture line, and this is where the cephalhematoma would occur. This is an actual depressed skull fracture. Another thing that you'll find, okay, here's the suture line up here, and here, there's your bleed, and so your cephalhematoma will develop over several days' time, and then as it starts to resolve, you will feel what's known as the volcano rim or a crater, and that's the edge of the cephalhematoma. And here's a baby that can confuse you. This baby has bilateral cephalhematomas, one on each side. So it can fool you, but it's not crossing the suture lines. So as the cephalhematomas come to meet in the center, you should feel basically like a little groove. All right? So actually the shadow is better than the head. Here, if you look at the picture, you go see how it goes up, and then all of a sudden it shoots up? There's your cephalhematoma. And there's one on the other side coming down, but you can see that groove right there in the middle where the two of them come together. So cephalhematomas do not cross suture lines. Here's a happy baby. Happy as can be. He's got a cephalhematoma. Look at the size of that thing. See how it stops and it does not cross over to the other side? Doesn't bother him. He's not hurting at all. Okay. This is what we call some molding and a little bit of caput. So when the head is stuck in there, you get swelling of the scalp. At the same time, you do get a little bit of molding, meaning that the sutures may override a little bit. And that's to make it easier to come out. That's why you have sutures, so that it's easier to come out, and so your head grows as your brain grows. Subcutaneous fat necrosis is another type of birth injury. And when you are reading the test question, you should be thinking of a birth trauma, or you should be thinking of like forceps delivery, something like that. They will be these firm, rubbery nodules. And you can palpate them anywhere. They can be on the cheeks, they can be on the buttocks, also the back or the extremities. They can be pretty much everywhere. Let's see if I have a brachial palsy here. Yeah, okay. Some other injuries are the palsies, the brachial palsies. Okay. Herbs, who said that? They beat me to the front. Gosh, the front row is hot today. Now, we're all hot, right? Okay, so this is an herbs palsy. And the brachial palsies occur when there's a stretching of the brachial plexus. So you can, again, be reading your question and be looking for like forceps delivery or some kind of difficult delivery. That's usually what causes the trauma, which then leads to these palsies or cephalhematomas or things like that. So we have basically Herb Duchenne's palsy and Klumpke's palsy. Herb Duchenne's palsy, which is this one right here, involves C5 and C6. And this is the typical position that the baby's arm will assume. It's known as the waiter accepting the tip. So the baby will be like that, waiting for the tip so they can seat you, right? This is the waiter accepting the tip. Now, in the test question, they may throw in either that C4 is affected, or they may throw in that there's an ipsilateral hemidiaphragmatic paralysis. And that means that C4 is affected. So it works both ways. So look for that. So generally it's C5, C6. But if you have a hemidiaphragmatic palsy on the same side, that's C4. I don't have a Klumpke's for you to see, but I can show you, because a Klumpke's is basically what they call the claw hand deformity. So they'll go like that. That's a Klumpke's, and that's usually C7 or C8 to T1. Okay, and you can actually have a Horner's if you have some of the sympathetic fibers of T1 affected. You can have a Horner's. And how do you remember what Horner's is? Yeah. Okay, so Horner's a guy whose forehead is dry, can't see the sky, and has a small eye. Okay, so there's anhidrosis, ptosis, and meiosis, right? Horner's a guy whose forehead is dry, can't see the sky, has a small eye. I learned these from you guys over the years, believe me. Clavicular or facial palsy. There you go. Facial palsy. This is the normal side, because the baby is crying and these muscles are working. The muscles aren't working over here because they're not being innervated. So the affected side is the side that doesn't move at all. Most of these palsies, Klumpke's, Herb Duchenne's, facial palsies, most of them are milder, and it's just some traction and stuff, and they do get better. Very rarely does like an Herb Duchenne's, they might need a little bit of physical therapy and stuff like that, but that's about it. They're fairly mild for the most part. And this will generally resolve with time also. Okay, right here we have a clavicular fracture. See it right there? And this one, you see it all connected. So there's the clavicular fracture. And the clavicle is the most commonly fractured bone during delivery. So you're going to look in the test question for a large for gestational age baby. Look for like a 9-pounder or something like that. Large for gestational age baby. Look for some kind of difficulty in delivery like a shoulder dystocia. And then in the test question they might start talking about the baby might not move its arm that well, or has an asymmetric Moro response, or the mom notices a lump when she brings the baby in for the first checkup. And that means that the callus is already forming. So for the most part, these things take care of themselves. You don't need to splint the baby or put them in a figure of 8 or anything like that. Usually by the time you see them, if you missed it in the newborn nursery, it already has a callus forming. On physical exam, though, besides, like I said, the asymmetric Moro or the baby just leaving the arm there, you may feel crepitus right over the affected side. And crepitus is that crunchy feeling that you see, that you get, or like when you pop those little bubbles, the little packing bubbles, and you pop them. That's crepitus. So that's what you will feel on physical exam, or you may actually feel the callus a little bit later on, in about a week or so. And you really don't need to do anything about it. Subconjunctival hemorrhages. These are very temporary. You'll see them. They're just these. I'll show you a picture when we do the eye. But you'll see that the blood is there, and usually it's because as the baby's coming out, there's a lot of pressure there, and they'll resolve with time. Okay, some congenital anomalies that we see in the newborn, and we kind of will talk about them now, and we'll talk about them throughout the whole time we're here over the next couple of days. The eyes. First of all, we'll look at, this is a coloboma. Okay? I'm not going to give you chocolate for that one. And it's right there. Okay, so coloboma, look at the iris. See the iris there? And there's an iris, the rest of the iris comes around this side, but see right there? There's a gap. So there's a coloboma of the iris. It's just a defect there. Sometimes you can have a coloboma of the eyelid, you can have a coloboma of the choroid, you can have a coloboma of the retina. It goes all the way through in development. But this is an easy one to spot. They call it the latchkey eye also. Okay, the latchkey. And nowadays everybody's got those cards to get into their rooms and all that. You might not know what I'm talking about. But that's the old houses. That's what the keys were like. So that's a coloboma. Now, this one is what we call aniridia. So there's lack of an iris. I don't know, in the cheap seats you probably can't see as well. Okay? But if you look around here, it's all black. There's no iris on either side. Okay? So this baby does not have a colored part of the eye. It's aniridia. The association you're going to make is aniridia plus hemihypertrophy. Hemihypertrophy means that one side of your body is bigger than the other side, like you've been working out on one side only. Okay? If you see aniridia and hemihypertrophy, you should be suspicious of a Wilms tumor. There's a higher association of Wilms tumor when you have the first two. And we're going to talk a lot about associations over the next few days. Right? So aniridia plus hemihypertrophy equals Wilms. Okay, this is a cataract. It's not in your notes, but this is a congenital cataract. Okay, we talk about reflexes in the eye, right? And when we talk about eye, we'll mention them briefly, but we'll talk about them right now too. We learn by repeating ourselves. So the first thing, you should always look in the newborn for a reflex. The normal reflex, when you look with the ophthalmoscope, is a red reflex. The light bounces back and it should be red. In this particular case, you have no reflex, which means that there's an opacity in the lens. That's a congenital cataract. Or maybe that baby might be 3 weeks old or 6 weeks old, I don't know, has galactosemia and is developing a cataract. Who knows? Because there's a higher association there. So this is a cataract. If you get a white reflex, so we're going to talk about basically white and red. And the red reflex can be red or orange or tan. Okay? If you get a white reflex, you should be thinking of a retinoblastoma until proven otherwise. Okay? That's another association. And then this is no reflex. This is just that the light's not passing through. So you have a lens opacity. That's a cataract. Okay. Preauricular skin tags. Here's another preauricular skin tag. And preauricular skin tags, for the most part, are just a normal variant. Doesn't mean a thing. But there is a slightly higher association with cleft lip and palate if you have a preauricular skin tag, just a little extra piece of skin there. If you have a preauricular dimple, obviously this is not a newborn, but they don't come out like that. But see that little dimple right there? That's known as a preauricular dimple or pit. There's a higher association with hearing abnormalities if you see them. Again, for the most part, they're normal variants. There's nothing else wrong with the child. They don't have any problems, but there is a higher association. And always remember, this is what we call microtia. This slide is getting beat up, but microtia. If you see grossly malformed, misshapen ears, there's a much higher association with renal abnormalities. So when you're reading your test question, you should be thinking of those things. Okay, really bad looking ear. Maybe you should be thinking about some kind of renal problem like, hydronephrosis, or the ultimate example is Potter syndrome. I'll show you a picture of that on the last day. This is not in your notes, but it's called macroglossia. Big, big tongue. See how big that is? Okay, that can actually obstruct the airway. Now, macroglossia can be seen in children with Down syndrome, for example, or it could be just an isolated finding. It's also common with Beckwith-Wiedemann syndrome. We'll talk about those syndromes on the last day. But this can cause feeding difficulties, and this can cause airway problems. Usually, as the child grows older, the face and the mouth will grow and kind of grow out of that. But sometimes these patients who have severe problems will need resections of the tongue, actually. Okay, this is ankyloglossus. Again, this is not a baby. A lot of teeth. This is known as ankyloglossus or tongue tie. And generally, you don't need to do anything about it. A lot of people would like to snip that. There's a nice little artery that runs there, and it can really bleed a lot if you snip it. Generally, you leave it alone. Most children, if they can get their tongue out to the gums, which most of them can, they will be able to nurse well, they will be able to speak well and not have any speech impediments, and they'll kiss well when they're older. It's not a problem. Okay? I don't have any neck ones to show you just yet, so we'll talk briefly. Branchial cleft cysts. They form from the branchial clefts that don't completely close. And generally, they are unilateral, but they can become infected. They can drain, and they'll require antibiotics, and sometimes they need to be closed or removed. Congenital torticollis, also known as wry neck, W-R-Y, wry neck. And that's just basically a balling up of the sternocleidomastoid, and the child will keep its head to the side. And you can sometimes feel like a knot on that side of the neck. And generally it's treated with just passive range of motion. You just move the head to the opposite side. I stress the word, the opposite side. I saw a baby once who was like 6 or 7 months old, and I said, gee, your baby, does he always keep his head that way? And they said, yes, and Dr. So-and-so, my partner, told us that we had to do some exercise. I go, good. And what have you been doing? Oh, we've been doing the exercise. And the baby was like this. So what have you been doing? I said, well, we've been going like that. So I'm sure my partner didn't teach him to do it that way. You have to go the opposite way. Generally, that does the trick. Now, some patients who have torticollis may have a hemivertebra in the neck, sometimes associated with certain syndromes. But for the most part, it's just that the muscle is balled up there, and just gentle passive range of motion takes care of it. Okay, as we move along on our physical, the chest, this is a baby with breast hypertrophy. And again, newborns may have some breast hypertrophy simply because, again, it's a heightened response of the receptors to circulating hormones, and it goes away as the baby gets older. But we see this quite frequently. And sometimes you might actually, in the newborn, you might see a little bit of drainage from the breast, a little bit of discharge. Some babies or some people will have supernumerary nipples. They're also known as polythelia. And they will be anywhere along the mammary line. So generally they're here, but the mammary line runs all the way up this way, down, and actually onto your thighs. So you can have accessory nipples anywhere along the mammary lines. There is an association with supernumerary nipples and renal and cardiovascular anomalies, although most patients that have supernumerary nipples don't have any problems. And you also need to know Poland syndrome when it comes to the chest. In Poland syndrome, the major thing is that there's an absence of the pectoralis muscle, and there's amastia on that side. You can also have some rib deformities, webbed fingers, and some radial nerve aplasia. But the main thing that I keep in mind when I hear Poland syndrome, okay, amastia and an absence of the pectoralis muscle. And just you can tell when the patient takes their shirt off, or when you examine the patient, you can see it right away. I have a couple of pictures of pectus excavatum. Again, these are not newborns. Pectus excavatum is also known as funnel chest, but you will see it in a newborn. They're born with this. And you also have what's known as pectus carinatum, or pigeon chest. And again, generally, these are just normal variants. You don't do anything for them. You just leave them alone. Very, very rarely do they cause cardiac problems. Not this one, but the pectus excavatum may cause a cor pulmonale over time, but for the most part, it does not compromise hemodynamics or cardiac function. And the most common reason for having these fixed is just purely cosmetics. Okay, in the abdomen, other congenital problems in the abdomen, polycystic kidney, that's what you see here. The most commonly, sounds like a test question or a test concept, right? The most commonly palpated mass in the abdomen in a neonate is polycystic kidney. Probably number 2 is going to be a very large bladder, maybe secondary to posterior urethral valves. But number 1 in a newborn is going to be polycystic kidneys. Umbilical hernias are very commonly seen in newborns and even older children. Okay? So you have an incomplete closure of the fascia of the umbilical ring, and you get an outie. Okay? Now, grandma is going to tell you to put a silver dollar or a quarter on it and tape it down. Okay? And the doctor is going to say to leave it alone. And after about a year, they'll have closed either way. You can't even do a phone call for a quarter anymore, right? So you don't even have the right change if you have a quarter on it. So there's no difference in taping it down or leaving it alone. Okay? You just leave it alone, and most of them will close by the time they're 5. About 99% of them will close by the time they're 5. A large majority by the time they're 1. And if not, then the surgeon can just take a little stitch and fix it. This is an omphalocele. Okay, remember your embryology? And somewhere along in utero, the intestines come out, they do a 270-degree flip, and then they come back in. Forgot to come back in. Okay? So the omphalocele is covered by a sac. So you really can't see the intestines per se because it's still covered by the sac. And so it comes out of the umbilicus. It'll be a midline defect. This is a surgical emergency. Most of the times you know this is coming out because of ultrasound, so the team is ready when the baby is born. So remember, omphalocele has a sac. Gastroschisis does not have a sac. So gastroschisis is actually to the right of the umbilicus, and all the guts come out. And since it doesn't have the sac and it's not as contained, there's a much higher risk for volvulus and malrotations. And so you have more ischemia and necrosis because of you're cutting off the blood supply. And again, it's another surgical emergency. And for the most part, if you've ultrasounded the mom, then you know that this is going to happen soon, so you kind of have the team waiting for it when it happens. Okay, anybody guess what this is? Besides, it's a boy? Huh? Imperforate anus. Anybody over here say that? This side hasn't really... Everybody's pointing to him. No, not to you. To him. They weren't pointing to you. But you can have one too. Here. Okay. All right, so this is an imperforate anus. Probably a hydrocele too. All right? So you never, ever take an infant's first temperature rectally. All right? Because sometimes this is easy when you can see, hey, there's no opening there. But sometimes it's a little bit higher up. It's a little shelf. And when you take the thermometer up, you are making it from imperforate to perforate. And that's not the right way to do it. Okay? So you never take a first temperature rectally in a newborn. And this could be a reason why a baby hasn't pooped in the first 24 to 48 hours of life. And you really should look down here. Okay? Because the best physical exam is done by the mother. Okay? They're going to check their baby from top to bottom. And they're going to say, doctor? And you're going to look pretty... Oh, yeah, I forgot about that. Okay? So there's an imperforate anus. All right. Some genitourinary congenital abnormalities. This is an epispadias. This is where the opening of the meatus is going to be on the dorsum. Okay? And this is hypospadias, which it can be anywhere. It's here on the ventral side. It can be on the shaft or at the very base of the shaft. If it's right there, this is known as a first degree. If it's along the shaft, it's a second degree. And if it's at the base of the shaft, it's a third degree epispadias. Usually they'll have like this hooded prepuce, which is also known as chordee, kind of bent down and a hood around it. And it is really much, this is a contraindication. Hypospadias, is a contraindication for circumcision because you're going to need all this tissue eventually to help fix things, okay? So you need to know hypospadias. All right, undescended testicle. Testes are going to be undescended, retractile, absent, or descended. Retractile testicle means that you have a very active cremasteric reflex, and it just slides right up, okay, when you touch the baby or when it gets cold or whatever. Undescended testicle means that you can palpate it in the inguinal canal, but you can't bring it down. Or it might be higher up, and you may not palpate it. You may need to ultrasound them or MRI them to look for it. If it's truly undescended, if it has not come down by 1 year of age, you need to surgically bring it down because there's a much higher risk for malignancy and it becomes atrophic. So you need to bring them down by 1 year of age. If after a year of age it hasn't come down. Okay, what do we have here? Bilateral hernias. There's a lot of bulging here. Okay, Dad is not just proud of this boy. Okay, this is bilateral hernias here. What's this? Ooh, I get one. This one's for me. That's an Epstein's pearl. Okay, I showed you one in the mouth. Did you say that? Do you have witnesses? Or accomplices? You get a good catch, so you get one too, just for making the catch. I made it harder for you to catch that one. Okay, this is an Epstein's pearl. I said there were, and anywhere that there's mucous membrane, so it's not just in the mouth. So this is the penis, but yes, it is there. Okay? And I showed you the hydrocele was the imperforate anus picture. That was a 2-for-1. See? This is the hydrocele. It transilluminates. Hydroceles should not reduce. Hernias do. Hydroceles don't. Okay? And hydroceles, generally, they can go away. Just a couple of things about the extremities that are not in your notes. Okay, so we'll go over them now. And this is what we call syndactyly. S-Y-N-D-A-C-T-Y-L-Y. Syndactyly. And you need to know, in this particular case, is this one finger or two? How do you know? An X-ray. If you see two sets of bones, it's two fingers, and you can probably get a good surgeon to take care of that. Okay? If it's one bone, it's really one finger, and so you don't want to start doing anything there. This is what we call polydactyly. There's an extra finger. Okay? That's a pretty good finger. You might want to leave that one because it's got bone, vascular supply, and everything. What's the pitcher for the Marlins? The relief pitcher for the Marlins. Any baseball fans? Come on. He has like 6 fingers on each hand. It'll come back to me. I can't remember his name. All right. This is also polydactyly, but this one is easy to do. It's just this little stalk. So there's really not any bone here, and you can just tie that off securely with a suture, and it just turns colors and falls off. Okay, it auto-amputates. And this is what we call an amniotic band. What's happened is that there's been a little tear in the amnion in utero. The baby stuck its hand through, and when it healed up, it kind of compressed. Hey, that's an easy one. That's a good one. Sometimes you can have phocomelia. You can have parts of your arm missing, or a lot of deformity in the hands, or more of the arms if it's higher up. So that's an amniotic band, and here's the mechanism. It tears, you stick your hand out, and when it heals, now you've lost circulation, and so you have phocomelia. So depending on how severe it is. All right, so we'll pick up with some neonatal screening tests. And depending on where you live, there will be different screening tests. Let's go to this question. A 1-month-old, fair-haired, fair-skinned baby presents with projectile vomiting of 4 days' duration. Physical exam reveals a baby with eczema and a musty odor. Which screening test would most likely be abnormal? Now, these babies, he presents similar to pyloric stenosis. It's 1 month old, and he's got projectile vomiting. Okay? But they're throwing in now the eczema and the odor. So this is a baby with phenylketonuria. That would be the answer. That's the test that would be abnormal. Depending on where you live and the incidence of certain diseases, there will be newborn screening for certain diseases. But the big three that you need to know are going to be phenylketonuria, galactosemia, hypothyroidism. In some places they test for maple syrup urine disease. In other places they test for sickle cell anemia right away and stuff. But those are the big 3 metabolic ones that you need to know that are normal testing in almost every state, if not every state. Phenylketonuria results from a defect in the hydroxylation of phenylalanine to tyrosine. And it's going to be autosomal recessive, and you need to know that. Okay, a lot of these questions you're going to need to know modes of inheritance. Because they may ask you, they may throw out this particular question instead of which screening test would most likely be abnormal. They might ask you, what are the odds of this family having another affected child? So you need to know, number one, that this is phenylketonuria. Number two, you need to know that it's autosomal recessive. And then you can say that they have a 1 in 4 chance of having another affected child. That's the kind of questions they ask, right? Those questions within a questions. So you need to know inheritance patterns. So this one's autosomal recessive. It occurs about 1 in 10,000 live births. Usually, the babies are normal at birth, and mental retardation is the most common manifestation. The vomiting, like we said, is projectile and can resemble pyloric stenosis. And another key is the way the infants look. They pretty much, these patients with PKU, pretty much look alike. They're fair-haired, they're fair-skinned, they have blue eyes, for the most part. Okay? They may have a rash that looks like eczema or atopic dermatitis, and they can have a little smell to them that's kind of distinctive. But look for fair-haired, fair-skinned, blue eyes. The routine diagnostic test, the newborn screening test, is a great test. It's common enough, that's why you screen for it. It's best done at about 48 to 72 hours after starting to take in protein. Okay? If you're just taking dextrose, you're not being exposed to any new protein, so you may not build up levels quickly. Remember, it's an amino acid disorder, so you have to be taking in protein. So it's usually best at around 48 to 72 hours to actually do the test. If you have a positive screening test, then you should obtain blood levels of phenylalanine, which will be high, and you should have normal tyrosine levels. The treatment is dietary. So you're going to treat them, initially you put them on low phenylalanine formula, and later on you put them on a low phenylalanine diet. Remember that the diet drinks that everybody has nowadays, if they contain aspartame, there'll be a warning. There'll be a warning on the label, on the can or the bottle saying, phenylketonurics, this contains aspartame, it has phenylalanine in it. So it's dietary restriction of phenylalanine. It's a balancing act because you need some amount of protein in your diet too. So you have to watch and restrict your diet. Complications, there's again a high rate of mental retardation. They can have microcephaly and congenital heart disease. And you need to, if you're pregnant, you need to, and you have PKU, you need to really watch your levels and follow your diet. The next one is galactosemia. Galactosemia is from a defect or a deficiency in galactose-1-phosphate uridyl transferase. And so what happens is you cannot metabolize the galactose, and it accumulates. The levels will accumulate, and it'll accumulate in the kidney, the liver, and the brain. It is also autosomal recessive. There's one variant called the Duarte variant. Duarte variant really is asymptomatic. They don't have any clinical significance. Babies will have a variety of symptoms. They can include vomiting, jaundice. They can have hypoglycemia, seizures. I showed you cataracts earlier. Galactitol will accumulate in the lens, and so that forms the opacity in the lens. They may have a big liver and spleen and gain weight poorly, and they have a very high risk of E. coli sepsis. We took care of a child about a year ago in our intensive care unit and presented just like that. Came in, septic shock, and grew out E. coli, and he had galactosemia. He had an abnormal screening test. So I've seen my 1 in 60,000, I guess. All right, so look for a higher incidence of E. coli sepsis. Again, you're going to diagnose this from newborn screening tests. It's going to be your initial diagnosis. You can do prenatal screening. And the treatment is going to be, again, eliminating galactose from the diet. One of the few contraindications to breastfeeding is galactosemia. You have to put those babies on soy formulas. And even though you treat them, a lot of them don't do as well. It sounds simple to say, oh, eliminate galactose from the diet, but they don't do as well. And they will have developmental delay, may have speech and learning problems. Hypothyroidism, congenital hypothyroidism, we'll discuss when we do the endocrine chapter. This is an infant of a diabetic mother. Okay, you are called to see a 9.5-pound newborn infant who is jittery. That's a big baby, 9.5 pounds. Physical exam reveals a large plethoric. Plethoric is a very red baby. It's also known plethoric or ruddy, R-U-D-D-Y, who is tremulous. A murmur is heard. Blood sugar is low. Okay? So an infant of a diabetic mother is an infant that is born to a mother who has diabetes or develops gestational diabetes. They tend to be what we call macrosomic. They tend to be huge. See how big this baby is? Okay? And this baby has an IV. Why? Because they tend to develop hypoglycemia. Why? Well, they have high circulating levels of sugar. And so what does the baby do? The baby can produce insulin. So this baby's been basically at the buffet, all its intrauterine life. If the blood sugars have been high, this baby's been at the buffet for a long time. Insulin is also a growth hormone. So not only is he getting lots of calories, it's also a growth hormone. So what happens when the baby is born and the cord is clamped, you have high circulating insulin levels, and now the baby's glucose supply is basically restricted and cut off, so they get hypoglycemia. So that's how many times they'll present. They'll be big babies, and they'll have the signs of hypoglycemia. They'll have jitters and tremors. And then you do a blood sugar, and it's low. Okay? So maternal hyperglycemia leads to fetal hyperglycemia, which leads to hyperinsulinism. Insulin is a growth hormone, and it contributes to the babies being big and having problems. They don't all, but a lot of them look big like this. They tend to have these chubby appearance. And so there you have the word ruddy, plethoric complexion. They tend to be large for gestational age. And we're going to talk about that concept in a little while. Large for gestational age and small for gestational age. Since they're big for their age, for their gestational age, they can have trauma, birth trauma. So look for a big baby, broken clavicle maybe, right? Hypoglycemia, infant of a diabetic mother, big baby like that. Imagine that guy, okay? That could easily break a clavicle. They will have hypoglycemia. They can have hypocalcemia and hypomagnesemia. And sometimes they will have respiratory distress syndrome because insulin can block surfactant production. So they can have a premature baby disease. They can have respiratory distress syndrome. Also remember, they talked about a murmur in this question. Infants of diabetic mothers are at much higher risk for hypertrophic cardiomyopathies. In general, they will get better over time, the cardiomyopathy. Usually if by about 6 months or so, it tends to go away. I recently took care of a baby that is really bad, has a really bad cardiomyopathy, probably secondary to this, and we're just kind of hoping it goes away. But look for hypertrophic cardiomyopathy high association with infants of diabetic mothers. They can also have hyperbilirubinemia and polycythemia. They're also at higher risk for other congenital anomalies, including ventricular septal defects, atrial septal defects, and transposition of the great arteries, or the great vessels. They also are at higher risk for what's known as lumbosacral agenesis, and a specific entity called the small or lazy left colon, which can confuse you with possibly like a Hirschsprung's or a meconium ileus. So they're at higher risk for a lot of these problems. The best thing to do is to try to control the mom's blood sugar while the fetus is in utero. And after birth, you need to monitor these babies, make sure that they don't bottom out, and then you basically have to treat their hypoglycemia until they readjust their insulin levels. Complications, we said that they are at higher risk for developing diabetes themselves, and again, since they're big, they have a higher risk of developing obesity as children. Okay. We're going to talk a little bit about gestational age when we talk about small for gestational age babies. Okay. And there's lots of different ways of estimating gestational age. First of all, you need to know if a baby is term, preterm, or post-term. And one way of doing it is knowing mom's dates, right? One way of doing it is biparietal diameter, femur length, things like that, last menstrual period. As pediatricians, we have the finished product, and we can sit there and look at these babies and say, yep, that one's term, oh, that one's post-term, oh, that one's a little early, because we have the finished product. And there are different scales and tables and charts that people will use. And it's usually there are variations one on another, and it's usually a physical maturity scale and a neuromaturational scale. Okay? And we've given you copies of those, I believe. And I didn't give you copies because they don't reproduce well, but you don't have to have them. Okay? Basically, this is known as the Ballard. Okay? And it's kind of there's the Ballard, there's the Dubowitz, there's different ones out there. But this is the Ballard, and it looks at baby's neuromuscular maturity. However, you can be thrown off if the baby is born, let's say the baby was depressed because of some sedation that the mom had. Well, when you're examining the baby's just laying there. That's why you should repeat the exam 24 hours later. Okay? And you look at posture, you look at muscle tone, things like that. And then physical maturity looks at the skin, the presence or absence of lanugo, which is the little peach fuzz that babies have, whether they have plantar creases or not, breast development, how the ear flips back. If the ear is stiff, it's good. At babies, if you notice, any of you have been have seen premature babies, their ear is very floppy. If you bend it over, it kind of just sits there. It doesn't flap back because it doesn't have stiff cartilage yet. And then the genitalia. And what you do is, and you won't be asked a question like this, but you determine the baby's gestational age by looking at all these things, and then you plot the baby's head circumference, the baby's weight, and the baby's length, and those things will fall into a certain scale, and then you'll know if the baby, I thought I had one, if the baby is post-term, preterm, you know by the dates, and then you'll know by this graph, you'll know if the baby is appropriate for gestational age, large for gestational age, or small for gestational age. So when we talk about small for gestational age, it doesn't matter whether the baby's a preterm, post-term, or term. It just means that the baby's size is appropriate or adequate for that particular gestational age. Okay, so if the baby is 35 weeks, is that the right weight for that baby? Yes or no? That's what you're answering when you're talking about small for gestational age or not, or large for gestational age. Okay? This is a slightly preterm baby. How do I know? Well, I put the slides in, so I know. Okay, but this is a baby that is not, the muscle tone is not so good. Okay? See how the baby's arms are kind of just limp? And even though there's some flexion here, there's not a lot of flexion. The baby's skin is very shiny. Okay? And that means that there's very little subcutaneous tissue. So the baby hasn't had time to develop that yet. The genitalia. The genitalia, the labia majora are wide out here and are not covering the labia minora. Okay? And there's very little breast development here. So those are some of the things that we use to look at and determine if a baby is preterm, term, or post-term. And then we weigh them and measure them and find out if they fall into normal ranges for those gestational ages. If they fall below the normal range for that, then it's small for gestational age. Here's another one. Very little subcutaneous fat. Again, kind of flaccid. The genitalia. And again, not very much development of the breast. In males, the scrotum gets darker as they get closer to term. It develops more wrinkles, and the testes descend into the scrotum. So you can look at the male scrotum and help determine gestational age. Again, this is a preterm baby. Look at the labia majora way out here, and they're not covering up anything. There's also very little subcutaneous fat, as Forrest Gump would say, in the buttocks. Okay, this is the lanugo. Okay, so he doesn't really need a shave. He's just very preterm. That's a term baby, okay? That's a lusty cry. If you could hear that baby, that's a lusty cry, okay? So obviously there's a little bit more mass to this baby. He's got some subcutaneous fat, all right? The baby is flexed at the hips and the knees. Look at the difference in flexion between that baby and the first one I showed you. Look at that difference in flexion, okay? Look at the breast development, okay? His foot's covering up the genitalia right now. This is a post-term baby, okay? Most babies will start to peel at about 2 weeks of age. The skin starts to peel, and mother's like, what do I do about it? Do I put lotions on it? No, you leave it alone. Well, this is a baby that was born today, and he's already peeling because he's been in too long, so he starts to peel anyway. And their nails tend to be longer. Okay? So there's a post-term baby. This is what we call a small for gestational age baby. Okay? Now look at this guy. He's got much better muscle tone than the first baby I showed you. Look at the arms. Look at the legs. Look at the genitalia. Okay? Really covering up the breast so you can't see as well. So this is a baby that is probably a term baby, but he's kind of small. So this is what we mean by small for gestational age. They're scrawny. Now why are they so little? A lot of reasons. We'll get to it right now. Okay? So, in this particular case, a term infant weighs 4 pounds at birth. Physical exam reveals a small infant with a disproportionately large head. And that you can kind of see here too. The mother has a history of smoking during the pregnancy. There's a risk factor right there. Okay, smoking during pregnancy. So this is a baby that is small for gestational age. It's also known as intrauterine growth retardation, or IUGR. So those are infants whose birth weights fall below the third percentile for their calculated gestational age. Doesn't matter whether it's 40 weeks, 41 weeks, 37 weeks, 35 weeks. It doesn't matter. It's below the third percentile for that gestational age. And we divide it into symmetric and asymmetric. Symmetric means that the baby is completely the same size, same proportions. Asymmetric, which is what this baby is, the head is a little bit bigger in proportion to the rest of the body, is actually in your notes, it's a misprint. Those babies have a better prognosis. That means that the brain has been spared. There has been some brain growth, so they can catch up. So asymmetrics tend to do a little bit better. So you're looking for an asymmetric SGA baby. That would be the best thing to have. The intrauterine growth retardation is associated with any factors that will decrease oxygenation to the fetus. Okay? So that includes fetal causes, such as chromosomes, or infections, such as the torch infections. We'll talk about those later. And those babies, the torch babies, tend to be proportionately small, so that's not so good. Congenital anomalies, or radiation, or insulin deficiency. Those are all fetal factors that can cause IUGR. There are placental factors, such as a small placenta, or a placenta that has lots of infarctions, or a partial abruption, because now the baby's not getting as much oxygen delivery, or a twin-to-twin transfusion. I'll show you that in a minute. And there are maternal factors. So toxemia of pregnancy, hypertension, malnutrition. Mom is so proud because she only gained 7 pounds during pregnancy. Well, that's not good. You're not supposed to gain 7 pounds. You're supposed to gain more than that. Okay? Tobacco and alcohol use, narcotic use, all these things will affect the fetus and produce intrauterine growth retardation. Okay? Now, preterm babies can be proportionately small, and their weights will fall into the just normal for gestational age. Then even let's say you've got 2 babies, they're both 33 weeks. Well, the 33-weeker that falls into the 50th percentile for that weight is a normal. He's just a preterm baby. Now, you could have a 33-weeker that falls below that, or you could have a 35-weeker that falls below its weight, and that's the SGA baby, not the 33-weeker that's at the 50th percentile. So that's why you have to know. And they'll tell you, or you have to plot it on a chart. Okay? Ballard scoring helps you to determine the gestational age, and then you just weigh them and you'll plot them out. Okay? Complications, well, babies that are small for gestational age or have intrauterine growth retardation are at higher risk for mortality. They can have intrauterine or fetal death. They're at higher risk for asphyxia, which may produce a lower APGAR score at birth. And we go back to the APGAR. They are at higher risk for cold stress and hypoglycemia. Cold stress because they don't have any fat, and hypoglycemia because they have no glycogen stores. Two types of infants are at high risk for hypoglycemias. Babies that are really little because they have no glycogen stores, or babies who are really heavy because they're probably infants of diabetic mothers. So keep the two extremes are higher risk for hypoglycemia. And these infants of this SGA babies are at higher risk sometimes for polycythemia because they've had increased hypoxia, and so they produce more hemoglobin and more cells, and so they can have higher hematocrits and hemoglobins than normal babies the same age because of their persistent hypoxia. So a lot of different things that can affect them. Right, neonatal drug withdrawal. A 2-day-old infant is noticed to have coarse jitters and is very irritable with a high-pitched cry. A low-grade fever is reported, as well as diarrhea. Maternal history is positive for heroin use. So these are infants that are born to moms that have been actively using drugs. And many times the moms will say, oh no, as soon as I heard that I was pregnant, I quit. Okay? Well, now the baby is born and has all these symptoms. It means that the mom probably found out just before the baby was born, because if she quit a long time ago, the baby shouldn't have any symptoms. This mom has been actively using drugs. And so now the baby will go through withdrawal. And the most common ones are going to be narcotics. So heroin, maybe methadone, because now they're on a methadone program, and sometimes cocaine can cause withdrawal. So you need to know if the mom's taking anything. If she's not and the baby's doing this, well, you can still make the diagnosis with a urine drug screen on the baby. Okay, so you get a urine drug screen on a baby and it tests positive for opioids. Who's supplying the baby? Nobody. The baby was having it from mom. Okay, so that's how you would make your diagnosis. You have to have a good history, physical, index of suspicion, and then you get a urine drug screen. Okay, so depending on the drug will let you know when the babies start to withdraw. Heroin has a shorter half-life than methadone, so the babies will withdraw sooner, okay? Usually in a couple of days. Methadone can take a couple of weeks because it has a longer half-life, so the levels stay up a little bit longer. And you will see all these symptoms here, any or all. Hyperactivity, irritability, fever, diarrhea is a classic one. Low-grade fever, very fussy baby with diarrhea, unconsolable, always sucking. You should be thinking of withdrawal. They can have tremors or jitters, high-pitched crying. They can sneeze. They can be very restless, very difficult to console. Poor feeders. They can actually have seizures from withdrawing. All of these things, any or all. Usually it's a couple of them. It's not just one. It's usually a couple of these things present. And again, heroin is usually within 48 hours, and methadone can be a few weeks. Phenobarb also, you can withdraw from phenobarb. It takes a couple of weeks. Why? Because phenobarb has a very long half-life too. So again, history, physical, index of suspicion, a urine drug screen. And how do you treat them? Well, you can put them on long-acting narcotics like methadone. If it's the mom tests positive for narcotic, you put them on methadone, and then you slowly wean the babies. I work I'm an intensivist. I work in the critical care unit, and many times we have to sedate our patients quite a bit, and they will withdraw. So we put them on methadone, and then wean them off. Same thing with these babies. Sometimes, in addition to that, you want to minimize stimulus. You want to swaddle them. You wrap them up nicely. They like to be held tightly and closely. So you do all of these things. Complications of neonatal drug withdrawal. Well, these babies are at higher risk, again, for low birth weights and being an SGA. They are at higher risk for anomalies because these drugs are teratogenic. And they're at higher risk for sudden infant death syndrome. They're also at higher risk for mom's complications. So if mom is abusing IV drugs and she's sharing needles, then the baby's a higher risk for like hepatitis and HIV. So they're at risk for mom's complications too. Okay, respiratory diseases of the newborn. Respiratory distress syndrome is the first one. Infants, newborns, will have many nonspecific symptoms. It could be a respiratory problem, it could be sepsis, it could be a congenital heart disease, and they will present with similar symptoms. So sometimes it's very hard to tell what's going on with the baby in the first couple of days. And so if any of you who have been in a neonatal intensive care unit will see that a lot of these babies have pretty much the same problem list. Preterm, rule out sepsis, RDS, jaundice. Well, they have similar symptoms, similar pathophysiology, so they have similar problem lists. Respiratory distress syndrome, when you start reading the question, look for some of these things in this question here. Shortly after birth, here's the key, a 33-week, so you know the baby's preterm, so that's a key right there, 33-week gestation infant, develops tachypnea, nasal flaring, grunting, and requires intubation. Okay? So that could be sepsis, that could be a congenital heart disease, but it is a 33-weeker, so you start to think maybe it's RDS, respiratory distress syndrome. Chest radiograph shows a hazy ground glass appearance of the lungs. Now you really are suspecting RDS, and here it is. Okay? Here's a little bit of that haziness or the ground glass appearance that they talk about. Okay? Remember that respiratory distress syndrome is secondary to surfactant deficiency. So you're going to see it almost exclusively in preterm babies. So you're going to look for that in your test question. The younger, the more preterm it is, the higher the risk of it occurring. Remember, surfactant decreases surface tension, so it doesn't allow the alveoli to collapse. And if you have a decrease in that, then alveoli will be collapsing all the time, and you'll have atelectasis. And when you have a lot of atelectasis, you start to get this haziness or this ground glass appearance on the X-ray. Okay? When you have all this atelectasis, you have ventilation perfusion mismatching, and so your blood gases get all screwed up. And you're not oxygenating properly. Usually, the babies will present very shortly after birth with respiratory problems. And that can include tachypnea, nasal flaring, grunting. Okay? Babies don't know physiology. They haven't read the physiology book, but they know that if they grunt, it keeps alveoli open. Because when they valsalva, they're increasing the pressure in their chest. That helps to keep alveoli open. But now they got to take a breath, so they got to let air out so they can take a breath in. So they go, and they grunt. You can sometimes hear it with the stethoscope. Sometimes you can hear it without the stethoscope. So they will grunt to try to keep alveoli open. They can have cyanosis. Again, these are nonspecific signs, but you're going to look at the history, and you're going to make me a little more suspicious for RDS if they're preterm. Usually, it takes about 3 days. They might have, increased secretions, and you're getting all this stuff out. And then around the third day, if it's a classic, non-complicated RDS, many times that's when they start to get better, and they'll start to diurese. That's one of the first things that you'll notice is this baby's starting to diurese, and then the lungs are getting better. And they're weanable off the ventilator or whatever if it came to that point. There's not real test to diagnose RDS. It's clinical diagnosis, and your X-ray helps. Again, look for the ground glass appearance. See how the heart border is not that sharp over here? It's kind of hazy. You've got this stuff over here. And you can see sometimes air bronchograms. Okay? The worse that the RDS is, I always say, the more the lungs look like liver. Okay, so you'll start to see this black area here, it'll start to look more like that. And you can have actually complete whiteout of the lungs. That's how bad the RDS can be. Treatment of RDS, the first thing you want to do, RDS in the old days we used to call it hyaline membrane disease. You might come across that too. Treatment of RDS, the first thing is prevention. Okay? You would like to get that baby to term so that the lungs will be mature. Okay? You can give the mom steroids. So you try to hold off the pregnancy, the delivery until their term. In lieu of that, you give steroids to the mom. Steroids to the baby, once it's born, don't really help. We can also treat them with surfactant. Surfactant has really helped a lot with RDS. And we treat any other complications. So we have to ventilate them. We put them on the ventilator. They need fluids. They may need antibiotics because sometimes certain infections can mask, and it can be a pneumonia, not RDS. So you treat complications if they have a pneumothorax, whatever. Complications are listed there, include pneumothorax, plugging, intraventricular hemorrhages, sepsis. They can have pulmonary interstitial emphysema. They can go on to develop chronic lung disease, or what we call bronchopulmonary dysplasia in the old days, BPD. And this baby, look at this. This is areas of fibrotic lung here and here, and then you've got areas here that are so lucent with air trapping. This is bronchopulmonary dysplasia, or chronic lung disease. These babies have oxygen requirements. Here's some more atelectasis and fibrosis, and also here. And then here's another hyperlucent area where you have air trapping. Okay, so that's a complication of RDS, and that's where surfactant has really helped. Okay, part of the differential diagnosis, sepsis. We're going to talk about sepsis in a minute. This is transient tachypnea of the newborn. And for the test, you're going to be reading the question. You're going to say, okay, how am I going to tell them apart? They're both breathing fast. They both might be grunting. Well, usually transient tachypnea of the newborn, you're going to be looking for a term baby. And you're going to be looking for either a rapid second stage of labor, or you're going to be looking for a C-section. So they're not getting that squeeze, so the fluid is not being expressed, and they'll be breathing faster to help reabsorb that fluid. So generally, this is a disease. TTN, or transient tachypnea of the newborn, is generally a disease of term babies. And again, look for either a C-section or a rather rapid descent. And then the baby will have tachypnea, may require a little bit of oxygen. An X-ray, the lungs are fairly clear. You don't see that ground glass appearance. Here's a little bit right there. See that line? Right there? That's a little bit of fluid in the fissure between the upper and lower the segments, the lobes of the lung, but that's a little bit of fluid in the fissure, and it tends to go away with a few days, and they hardly ever need to get intubated. Okay, so that's TTN. Meconium aspiration syndrome. Again, this can produce tachypnea and grunting and flaring and a lot of times cyanosis. This occurs, you'll look for a history of meconium-stained amniotic fluid. Generally a term baby, but you just look for the question. You look for when they ruptured membranes, there is meconium staining. And you will see right here under this baby, there's meconium under the fingernails. Or you'll see meconium staining not just in the amniotic fluid, but around the umbilicus of the baby or underneath the fingernails. So that's meconium aspiration. Chest X-ray is typical of an aspiration pneumonia, just like if you had aspirated anything else. Now, any of you who have seen meconium know that it's like really thick pudding. It's supposed to be sterile, but if that stuff gets into your lungs, it can cause a big pneumonitis. And it causes plugging and air trapping, and it causes hypoxia. And hypoxia causes vasodilation everywhere else in the body except in the lungs. In the lungs, hypoxia causes vasoconstriction. So now you have shunting. Okay? So what happens in this newborn, you have shunting through either a patent ductus arteriosus or a foramen ovale. So what happens when you have shunting is you have more deoxygenated blood going out to the body, causing more hypoxia, causing more vasoconstriction of the pulmonary vessels. And then you have the next entity, which is persistent fetal circulation or primary pulmonary hypertension of the newborn. So meconium aspiration syndrome can actually lead to the next thing. The best thing to do for meconium aspiration is to prevent it with good suctioning of the oropharynx once the head is delivered. You just suction the nose, suction the mouth, and get that stuff out. The new recommendations when we teach pediatric advanced life support are now not to intubate these babies and suction them out, okay? Unless they're having significant respiratory problems and cyanosis. Otherwise, you just suction the mouth, the nose, and get that stuff out, because many times we'll have problems doing the other things. Okay? So good suctioning. Now, once the baby has this problem that they've developed the meconium aspiration syndrome, what do we do for them? Well, they can develop pneumothorax. We need to treat them. We need to ventilate them properly. We need to oxygenate them. We need to avoid acidosis and hypoxia. And that includes ventilator management. It also includes pulmonary vasodilators, such as nitric oxide. And sometimes babies have to go on ECMO, extracorporeal membrane oxygenation. Same thing with persistent fetal circulation. So we can kind of talk about both of them together. Okay? And then I think I threw that one in. This is meconium aspiration. Yeah. Right here. It kind of went up here and a little bit down here. So it really just goes any which way, is meconium aspiration. And then you can have air trapping and hypoxia. Now, I think you got this. There's a nice little algorithm. That's the one that was ones we gave you at the beginning. And this is how to go through your thought process and your differential diagnosis for a baby that presents a newborn in respiratory distress. They can present with very nonspecific signs: cyanosis, grunting, retractions, tachypnea, maybe apnea, maybe shock. And you should think of respiratory problems and then other problems, extrapulmonary problems. And we've talked about most of these. Respiratory, we've talked about hyaline membrane, transient tachypnea, meconium aspiration, and PFC. Pneumonias and pulmonary hemorrhages are less common, as well as pneumothorax. Usually the pneumothorax is as a consequence of the common things. Rarely do you get choanal atresia. We'll talk about that later. And sometimes you will have a diaphragmatic hernia. And I'll show you a slide of that later. Always think of the heart. We'll have a whole chapter devoted to the heart. Okay? And always worry about sugar. And this is very important. We'll talk about that when we talk about resuscitation, is hypothermia. Babies, newborns do not maintain their temperature very well, and they can get in a lot of trouble just by being cold. Okay, and then maybe there was a bleed in the brain or edema, or maybe it's the baby's depressed from medications that the mom got. Okay, so this is a nice algorithm with your differential diagnosis of a newborn with respiratory distress. Okay, I knew it was coming up. This is a diaphragmatic hernia. Okay, so classically, patients with diaphragmatic hernias, you're going to be looking for 1, respiratory distress. 2, scaphoid abdomen. So babies, when they're first born, most babies have the belly that sticks out, right? Those big bellies. Well, these babies have a scaphoid abdomen. That means that it's flat or sunken. Why? Because the intestines have gone up through the defect in the diaphragm. So, what did I say? Respiratory distress, scaphoid abdomen, bowel sounds in the chest, and your X-ray shows bowel in the chest. That's not supposed to be there. That's your intestines, and see how the heart is pushed over, and now you have some atelectasis up here. Okay? So that's what you're going to be looking for when you're reading your test question, or when you're actually examining the patient. Sometimes the test questions in the patient, they really do apply to life. Okay? So what do? Well, you need to call the surgeons and get this out and fixed. And then the real fun starts. The main problem with these babies, once you get that done, is that this lung is not very well developed. You have a pulmonary hypoplasia because you've had all this stuff up there compressing and hasn't developed well. And then this lung, isn't the greatest either. So that's when you run into trouble. So there's a diaphragmatic hernia, and your diagnosis will be made: newborn, respiratory distress, scaphoid abdomen, bowel sounds in the chest, and intestines on a chest X-ray. Look for those. Okay, you also got this paper, right? Yes, you did. You got that one, right? And this one is kind of superimposed on it. So let's talk a little bit about jaundice in the newborn. A 2-day-old infant is noted to be jaundiced. He is nursing and stooling well. Indirect bilirubin is 11.2. The direct is 0.4. Physical exam is unremarkable except for visible jaundice. Okay? You're not going to get asked 20 questions on this. You could have a whole test just on jaundice, though. All right, we need to first of all know what physiologic jaundice is and what pathologic jaundice is, because when you're reading this question, you need to start thinking about those things. So neonatal jaundice occurs when indirect bilirubin is deposited in the skin. Hyperbilirubinemia is going to be physiologic or pathologic, and the bilirubin itself would be described as unconjugated or conjugated. That's also important to know as you're reading your test question, because if we're talking about physiologic jaundice, it should be a high unconjugated, not conjugated when you read it. Okay. Bilirubin is going to come, the major source of bilirubin is going to be hemoglobin. You also have myoglobin and the cytochrome oxidase system, which are contributors. But the major source of bilirubin is going to be from the breakdown of hemoglobin. So how do we get physiologic jaundice? Well, number one, you have infants who are physiologically somewhat hypoxic in utero. So what do? They make more hemoglobin and more red blood cells. So when infants are born, they have higher hemoglobins, 18, 19. They have higher circulating red blood cell volumes. Their red blood cells don't live as long as ours. They live about 60 to 90 days. So as they're dying off, you're releasing all this hemoglobin. You have an immature liver that can't handle the load all of a sudden, hasn't cranked up its enzymes yet, and so it starts kind of storing it in the skin, and that's how you get physiologic jaundice. So the definition of physiologic jaundice is going to be jaundice that does not present in the first day of life. So if it's in the first day of life, you should be thinking pathologic, and you have a whole list. Okay? It does not, some people say 12.9, other people say 15. So there's a range. It doesn't go very high. It peaks around the third to fifth day, and by a week is going away, a week to 10 days. We will give preterm babies 10 to 14 days for it to resolve. That's physiologic jaundice. Anything that doesn't fit that definition is known as pathologic jaundice, and then we need to investigate it. So know the difference. Now there's another concept there, breast milk jaundice. Breast milk jaundice usually presents by 1 week of age. It's felt that non-esterified fatty acids displace the bilirubin from the albumin molecule, and so the babies get yellow, and you don't need to do anything about that either. And then there's a big one, the next one. Babies with conjugated, that's an important concept right there, conjugated hyperbilirubinemia and clay-colored acolic stools should be suspected of having biliary atresia. Okay, we just diagnosed one 3 days ago before I left. Okay? That came into our PICU after going home, came to the pediatric ICU, and had clay-colored stools and had a bilirubin of like 10, and it was about 7.7 conjugated, and the baby's now 5-6 weeks old, and had a clay-colored stool right in front of us. And I was like, whoa, great, I have a story to tell now when I go to New York. So the liver biopsy shows biliary atresia. That's a classic, okay? Conjugated hyperbilirubinemia in a newborn with clay-colored or acolic stools equals biliary atresia until proven otherwise. Okay, so how do you work up jaundice? Well, you need to know what the level is. You need to know whether it's direct, if it's conjugated or unconjugated. It's important to know what the baby's hemoglobin is. It's important to know what the mom's blood type is and the baby's. Because when we go through our differential, you'll see. Treatment depends. Phototherapy is very good for the unconjugated hyperbilirubinemia. It changes it to it photoisomerizes it to an easier metabolizable form, and you can get rid of it. You do not put a baby with direct or conjugated hyperbilirubinemia under the lights. They get what's known as bronzed baby syndrome. Nice tan. Okay? Doesn't do anything to the bilirubin. So it's only good for indirect or unconjugated hyperbilirubinemia. Sometimes babies go past that. They're still hemolyzing, and so you need to do exchange transfusions with the indirect. That's usually Rh incompatibility. Okay? And here's a whole list of neonatal hyperbilirubinemia. Let's go over it. It's in this particular table, It's overproduction, undersecretion, or a mixed, which is as how do you break it down, okay? So hemolytic disorders, such as blood group incompatibilities. Now, ABO, that's why when you're reading the test question, you need to know what mom's blood group is and what the baby's is. Or that could be the test that you need to order, and that could be the answer to your question. ABO is more common than RH, but it is milder. RH, at least, is treatable, though, right? Or preventable. How? We give the moms RH immune globulin. Okay? Okay, genetic disorders such as phagocytosis, G6PD. These show up a little bit later. Particularly G6PD, you have to be kind of exposed to something, right? With G6PD, you need to be exposed to some kind of oxidizing agent or to fava beans or antimalarials, dapsone, naphthalene. Okay, there's certain medications that can trigger this. So you need to, that's usually G6PD, when you're reading the question, you should look for a triggering event. I remember a baby admitted to when I was in training, in fellowship training, in the PICU, the baby was admitted with it was like an 18-month-old with a hemoglobin of 3. Okay? And the fellow who admitted the patient got a good history and found out that the older child had given her a mothball to eat. And so she started to hemolyze. She had G6PD. Okay, so there's usually an inciting event for G6PD. Okay? Hemoglobinopathies usually do not present in the neonatal period because you have fetal hemoglobin until a couple of months later, then that starts to be a problem. Vitamin K, yeah, maybe, but usually we just give a little bit of vitamin K. 1 milligram is enough. Okay, look for a history of petechia, hematomas, pulmonary cerebral hemorrhages, or swallowed blood. And that can be a source of jaundice in a newborn. Okay? Particularly if you've had a difficult delivery. If they tell you that the baby, and I think I have, is that next? Yeah, there it is. See? Facial bruising. So this baby was a face to pubes presentation, so he got beat up, and all this bruising, these are Mongolian spots. See how they're kind of just dissolving into the skin. This is not the baby, okay? This is the slide. Don't feel bad. It's not that he got cut up, it's my slide is beat up. Okay, I need to get a new one. But see how it just fades? Now this baby, that's all a collection of blood. So that's a potential for jaundice right there. So if you read that in the question, they say that the baby has a big hematoma or has bruises, that could be where your blood's coming from. Okay? Polycythemia. So if, again, a chronic fetal hypoxia or what's known as a maternal fetal or feto-fetal, this is the twin-to-twin transfusion, or placental transfusion, cord stripping. In the old days, blood's good for you, so a little bit more blood should be better for you. So they used to take the umbilical cord and just kind of strip it down towards the baby and give him a little extra blood. Okay? You can have obstructions. Okay, all these things can cause jaundice. And then over here in the undersecretion, that's when you get into the enzyme problems like Gilbert, Crigler-Najjar, things like that. Milk, human milk. Biliary atresia. We already talked about that. And then over here, the mixed, we have the torch infections, hepatitis, and sometimes, again, prematurity or infants of diabetic mothers. What do we do for these guys? Well, here's a twin-to-twin transfusion. I told you it was coming up. So these are twins. This guy got all the blood. Big. Little guy. Actually, he's going to do better than this guy. So he's at higher risk for problems. He's at higher risk for jaundice because he has a higher hemoglobin and all, and heart problems and all. Okay, so how do we treat? Well, phototherapy helps. When you put them under the light, you have to hydrate them and give them a little extra fluids. Phototherapy sometimes causes a little bit of diarrhea. That's okay. They're pooping out more of the bilirubin. Exchange transfusions. We always do double volumes. Exchange transfusions will remove circulating antibodies. They also remove bilirubin. And at the same time, they increase the hemoglobin because remember that they're hemolyzing for the most part. And so they're going to get anemic and they can go into high output failure. Don't worry about protoporphins. Okay? This is the extreme example of a baby that's been hemolyzing. Okay, this is what we call what? Erythroblastosis fetalis or hydrops fetalis. This baby's been hemolyzing in utero and had high output failure and has anasarca, and obviously is a non-survivor, and has anasarca and a big swollen placenta also because of this low hemoglobin, high output failure. Okay? And we always worry about, high indirect bilirubin and connectors and all that stuff, so that's why we treat.